Hi, today we have Dr. Peter Chen, who's joining us for this recording of the Beating Melanoma project. Thank you, Peter.
Thank you.
So we got another really great, talented physician and expert in melanoma. And Dr. Chen actually is a graduate of UC Berkeley with a dual degree of mechanical engineer and as well as rhetoric. And he subsequently got a master's degree from Stanford and medical degree from UCLA, and has been a radiation oncologist working at Hoag Medical Center since 2004. I'm actually one of his newer colleagues. I just joined Hoag, and we start sharing some of the patients. I thought this is a great resource for someone who has expertise to talk about radiation oncology treatment for patients with melanoma. Again, thanks so much for taking the time to talk to us.
Thanks for having me.
Yeah. Couple of things. First is, in what settings can radiation play a role in melanoma treatment? And maybe we can even step a little bit further back. I think there is some misconception, right, in thinking that radiation may not work as well, but those were some of the old research. Maybe you can comment on that to start out.
Sure, and that's a great point to bring up. If you look at our older textbooks, you will commonly see melanoma as being a subtype or histologic type of cancer that is resistant to radiation. And this was based on laboratory work with cell lines, which showed that the survival curves and the lethality of radiation may need a higher dose. But I think in reality, there are a couple of things to consider. First, in clinical practice, even as our textbooks were telling us that melanoma was resistant, we would see that melanoma in the body actually responded. And this went even back to the old RTOG protocols, which would show for metastatic disease response rates in the 60 to 80% range, and even complete response rates in the 20 to 30% range. So I think what really happened, or what happened in the body, or what happens with melanoma, is that it's a very heterogeneous disease. Sure. And in the body, one tumor is made up of many different types of cells, some of which may be resistant to radiation, but others which may be sensitive. And I think we've seen that also. If you look at the more recent textbooks, they will usually mention that it's felt that melanoma is more sensitive to radiation radiobiologically than previously believed.
No, that's great. I mean, I know the latest NCCN guideline and specifically included radiation treatment as one of the options for many different clinical scenarios. And maybe we can walk through some of those scenarios. And one of the things we see a lot is lentigo maligna, right? And those are the really early melanoma. I mean, I consider them, they are just melanoma in situ and very early stage of lesions, and they commonly found on the face, on the exposed site in elderlies. And treatment is usually the first line option, but there are many times the patient is too frail, too old, and we actually consult our radiation oncologist for using this modality. Can you just comment on, like, what that process is like, and how effective is it for radiation treatment for
Sure, yes. As you've mentioned, these are this is a disease that occurs in elderly patients in sun-exposed areas, and in addition, they can be fairly large lesions, and so surgical management could be either medically contraindicated or disfiguring. And so this is a case where, as a radiation oncologist, I could be called upon to treat. And we actually have a fairly good track record in terms of treating and controlling this disease. The Princess Margaret series is probably the most talked about series for lentigo maligna in the elderly. And they reported about 80 to 90% control rate with the use of radiation treatment.
So can you comment like, what kind of modality, and I mean, let's just say I'm a patient, and I went to see my surgical oncologist. I went to see my Mohs surgeon, and they tell me, this is too big, and perhaps you're gonna go see a radiation oncologist. I'm come to your office, right, with the lenticle malignant on my face. How does that consultation process go?
Well, I would talk to the patient about the radiation as a treatment option, and they probably discussed the surgical option and sort of the extent of surgery that would be required with their uh, Mohs surgeon or other surgeon. And as far as the process of radiation, I would describe a planning session, which would typically begin with an appointment where we would make a thermoplastic mask that would fit over the patient's face. And this is a material that, when placed in a warm water bath, becomes pliable. And then it can be stretched over the face and kind of form fit, a little bit like the Terminator, if you've ever seen that movie. And it hardens as it cools, and it helps the patients to get into and maintain the treatment position.
Okay.
After that, we get a CT scan, and that gives us a map of a patient's body, of a patient's anatomy, and that information goes into the computer planning system. And with that map, or specifically electron density map, we can calculate how a radiation beam is going to interact with tissue. It typically would take us a few days working on the computers to develop a radiation plan, and then the patient would come back for treatment. When they had treatment, there would be trained therapists operating the machine who would set the patient up on the table in the mask. The treatment plan would be verified. I would be supervising everything that would happen to them. And when they had a treatment, we typically, for lenticular maligna, for example, would be using an electron beam, which is a charged particle radiation, which still is ionizing radiation, so it's active against cancer, but it just penetrates superficially into tissue, and then the energy basically stops. So it's a really great way to treat skin lesions.
So the most important thing is, for patient who's listening to this, is the electron beam is superficial. It is not going to go deeper into the bones, the muscles, or the brain, right? Is that correct? I mean, I think this is one of the questions most people have.
Exactly. And we can modulate the energy of the electron beam. Sometimes we will use a bolus material, which will allow the beam to build up, but also keep it from penetrating too deeply into our target structure, so that we can spare the normal tissue behind it, which of course in the head and neck area is always crucial. So we want to do that as much as possible.
And I know that, you have a set dose. You don't deliver once, you deliver multiple fractions. I mean, multiple episodes, right? And then one of the question is, how many episodes, how many fractions typically? And then what's the frequency? I mean, I know it's 2 to 3 times a week. And also the question is, most patients have is, how much time do I need to lie there with this terminated mask and something? Is it something quick or something like, what is that like?
So fortunately, a single treatment with radiation does not take a long time. After the patient's set up on the table, in this case with an electron treatment, we have a beam that's going to be applied directly to our target area. The whole process may take about 10 minutes, including all of the setup time, with the beam being on maybe 30 seconds to a minute or so. During the treatment, you don't actually feel anything. So each individual treatment is pretty easy to take, but we typically do repeat these treatments. And this is another way that we can protect normal tissue. So the first way we have to protect normal tissue is by altering the distribution of radiation. We can do that by shaping our field to match the target area, as we were discussing, modulating the depth of penetration of the electron beam. But very importantly, we have this dividing of the dose into lower doses, which we also call fractionation, And that's a very important method of protecting normal tissue. And in fact, it's the reason why we have a radiation treatment at all. So what we're doing when we're dividing the dose or fractionating is taking advantage of the body's natural ability to recover from lower doses of radiation. And we're all born with this natural ability because we basically live in our radiation environment. Even unfortunately, as we're sitting here today, we're being bombarded with cosmic rays. And if we didn't have these natural abilities, we basically wouldn't survive as a species. So when we give a low dose, we're allowing the normal tissue to recover in between each dose of treatment. Whereas cancer cells, which are disorganized and have lost these exquisite abilities to repair from radiation effect, are killed off. So each subsequent dose will allow us to affect both normal and tumor cells within our target volume, but the normal cells will recover, whereas the tumor cells do not. And we repeat this and repeat this and repeat this. And by the time we get to a typical course, which may be 20 to 30 treatments, we now have an exponential difference between the effect of the radiation on normal cells, which are basically left behind, and the tumor cells, which are all killed off. And so I like to describe radiation in this way as a selective biologic weapon as opposed to a physical weapon. We're not burning or eradicating tissue where we treat. We're really selectively killing off tumor cells, much in the same way that if we gave an antibiotic, we would be selectively killing off bacteria with a poison, which is more active against the bad actors, the bacteria, as opposed to our body.
No, that's a very cool way of describing it. And it's a good way of thinking about how radiation works, right? And because most people thought it's just very contradictory towards most people's perception about how radiation works. And this is really great. And you mentioned, so a couple of things very important, and you mentioned a lot of this. I just want to sort of capture it and so people can understand it clearly. You typically, a course of treatment for lentigo maligna is about 20 to 30 fractions, meaning they have to come to your office to get the treatment 20 to 30 times. And each time, the planning session takes about 10 minutes or so, but the actual treatment with the radiation is less than 30 seconds or a minute, right? And so that's actually very, very important because that's one of the things that people always afraid of. They think that they somehow have to lie there, not moving for 10 minutes, which is not true, right? It's a really quick type of process. And just another question. So we talked about electron beam. The advantage here is that it's very superficial radiation. You basically want to target the skin because most of lentigo melanoma is actually very, very superficial. How do you decide 20 versus 30 fractions?
Well, so for this disease, we do have some flexibility. We have in our mind a certain radiobiologic dose that we want to achieve, and that's commonly achievable and achievable with a great side effect profile if we stretch the treatment out to that time frame. But at the same time, we have to consider that these are older patients. And in fact, you can use a shorter treatment schedule if a patient is, for example, if it's difficult for a patient to come out for that many treatments, we can treat with 2 weeks, 3 weeks. The issue here is that, as I was describing, the more you stretch the treatment out, the more selective the effect becomes, and we're more able to spare the normal tissue. So if we use higher doses per day and treat in a shorter time period, then we do run into more risks of mostly cosmetic effects. So we can leave a blemish on the skin, but sometimes it can lead to a scarring type issue, or in the worst case scenario, even some breakdown of the skin if the area is vulnerable.
That's what you try to avoid. And then that usually patient comes every day in a week or 2-3 times in a week?
Again, usually daily is an optimal schedule with the weekends off, and that seems to work well both um, physiologically with the way that our bodies react, and also socially because we're used to having the weekends off, and
Yeah.
patients don't like to come in on weekends, and staff don't either.
Yeah, I was gonna mention that the staff probably doesn't want to come either. No, this is great. I mean, I think one of the thing is I had a lot of experiences. We had a lot of patients who just not a good candidate for surgery for the lenticular malignant on the face. We always worked with our radiation colleague, so it's great. So let's maybe shift gears a little bit. Besides lenticular malignant, what other settings is radiation can play a role for treating melanomas?
So in the primary setting, we're usually not called on to treat melanomas because they are removed surgically. And when they are removed surgically, the local recurrence rates for melanoma are very low, usually less than 5%. So we're not going to gain much by treating the primary site. But there are some circumstances where we would consider that. So one of them is in, for example, a particular histology of melanoma called desmoplastic melanoma. This is a melanoma that carries certain mutations and is classified also by its appearance under the microscope. And for potentially many different reasons, this is a melanoma that recurs locally at a much higher rate. Could be as high as 15 to 25%. And so in those cases, we can consider doing radiation, particularly if a surgeon has some concerns about the margins, which can also be commonly at issue with this disease because they're usually pretty ill-defined and very spindly. Also, for the primary site, I've been called on to treat if a surgery is incomplete and if further surgery will lead to a suboptimal outcome. So sometimes there are, for example, large scalp melanomas where the surgeon really has done a large resection. There may have been a flap reconstruction, but then there's a positive microscopic margin for in situ disease, for example. And in some cases, when you always have to consider whether to do a re-resection, but if a further resection is not is going to be a major undertaking, then radiation can play a role in that setting. And then there are some areas of melanoma which are not easily resected. So mucosal melanoma, which is a rare entity, but it has come up from time to time.
Maybe we can define it for people, what does mucosal melanoma mean, basically?
So this would be a melanoma that arises from the mucous membranes, typically in the head and neck area. And this is an area, if it occurs in like the sinuses or deeper in the nasopharynx, structures deep within the head that are lined by mucosa but not easily resectable, then radiation also can play a role in the treatment at the primary site.
Yeah, I think one thing I also want to mention is one of the difficult thing about desmoplastic melanoma, the reason why it has such local high recurrence is that it has a tendency to sort of spread into the nerve, the neurotropic aspect of it. That's another name. But so obviously you sort of touched upon the limited role of radiation for primary lesions. But what about some in the adjuvant setting for nodal disease?
Yes, so it's so we know that melanoma does travel to lymph nodes, and patients with a higher risk melanoma may commonly have a sentinel node procedure to see whether there is disease. And we actually have had a randomized trial, and kudos to the Australians for performing this because they took patients with high risk melanomas, and this typically involved nodal disease, and it was a bit of a complex stratification, or the patients who were treated with radiation were treated on a bit of a complicated criteria set, which involved the number of lymph nodes and the location and the size and whether the cancer had spread outside of the lining of the lymph node. But they flipped a coin to say radiation or no radiation to the nodal basin or the area where the lymph node was located. And this was a positive trial in the sense that the radiation did what it was supposed to do. It reduced the local recurrence rate of melanoma in that area. And it did so by about 50%. So if you look at the groups, and they have 5-year follow-up reported, twice as many patients had recurrences in the lymph node area who did not have radiation, who just had surgery, as opposed to those who were also treated with radiation. Now, what was not observed in this study was an improvement in overall survival statistics.
Sure.
So we did not establish that this helped patients to live longer or more patients to be cured of melanoma with this intervention, even though it did improve local recurrence. But there could be many reasons for this. Perhaps the study wasn't large enough to detect that survival difference. Perhaps if we had another study that had different criteria, we would see this. So we're in a circumstance where when a patient does have a lymph node metastasis of melanoma, we have to decide, I think, on an individual basis as to whether to deliver radiation. And also, we have to consider what other therapies the patient may be having. So, for example, the study that I referred to, the TROG study or the Australian study, it was begun at a time when immunotherapy was not very prevalent. And so what we discuss in our meetings and academically is, well, how can we interpret this or apply this in an era where immunotherapy is commonly used? And you could argue either ways. You could argue that immunotherapy is better at controlling distant disease, so local control should be more important, and maybe the study would be positive for overall survival benefit. But you could also argue the opposite side, which is that immunotherapy would clear the local component, and perhaps the radiation would not have as much of an effect. And so it's an interesting debate that we may have for each individual patient. But I think the proof of principle, at least, has been established, which is that radiation should help with local control for patients. And then the question becomes, is that going to be worth it? Or does that make sense in the setting of any individual patient's case?
Yeah, especially in the setting of, we have all this immunotherapy at this point, right?
Exactly.
Yeah, and I think that is a debate that it's still a kind of a controversy like you're talking about. But coming back to that trial, did all these patients just have a positive lymph node biopsy, or did most of them also had a dissection?
It varied. So I would have to look back at the trial to see the exact numbers, because it was done as surgical practices have changed from doing full axillary dissections in the setting of any positive lymph node to just doing sentinel biopsy.
Biopsy, exactly.
Sometimes not even doing a sentinel, biopsy. So, I'm not sure exactly the numbers for each.
And another question I have is, does the adjuvant radiation create other added complications such as lymphedema, or is that added risk in that group of patients, or compared to the group that hasn't been treated, that was the same?
Sure. Yeah, that's a good question. And in the study, the most common side effect that was associated with radiation is a skin reaction.
Sure.
And so when we give radiation, you commonly get an irritation of the skin. The skin turns red. In some cases, it may heal and become a full kind of sunburny sort of reaction. This tends to be a temporary side effect and tends to go away within about 2 weeks after the radiation is over. But in addition to that, they did notice that for patients who were treated to sites that would affect the lower limb, they didn't actually report that there was a higher incidence of clinically significant lymphedema, but they were careful in this. They actually measured the limb size of patients for both arms. And the patients who had radiation did have slightly larger limb size for lower extremity, or for sites affecting the lower extremities, not for the upper extremity.
So that means they're more affected on the leg, not the arms, basically.
Exactly.
Okay. I just want for clarification. Okay, go ahead. Keep going.
Right. So I think a careful observer might notice that there was some lymphedema, but is it a clinically significant lymphedema? It wasn't really considered that per se, but we do have to consider that as
and another question usually is, how long did the study follow these patients? Because I mean, I think usually, I mean, is it just 1 year out or like 5 year out? Because obviously will that change?
Right. So the first report of the positive study was without long-term follow-up. And so they commented that they could not really make judgments, but they have published a follow-up on this paper. And I've seen their 5-year follow-up reported, and that's when they reported on limb size.
Got
and that as a late effect of radiation. And the benefit was maintained over those 5 years. So with long-term follow-up, there was still about a 50% relative risk reduction in local recurrence.
Got it. So another question to follow up, and we sort of touched upon a little bit. I mean, I think it's something very important to mention. Is it correct to think that the lymphedema issues usually are worse when you radiate the groin area versus the head and neck versus axilla?
Yes, I think that's my own, personal clinical observation, but also I think borne out in that randomized trial. The groin area is more vulnerable to developing significant lymphedema.
What are other risk factors that will, predispose someone to have more risk of lymphedema?
Typically, it's perhaps in someone who's more obese and maybe more sedentary. So a fit and athletic patient would be at less risk for developing lymphedema. But I don't believe that was specifically stratified in the TROG trial.
Okay, shifting gears again. Let's move up the chain. Brain mets, bone mets. Does radiation play a role here?
Yes, so melanoma, unfortunately, is a disease when it metastasizes, commonly metastasizes to the brain. And so I see that often. But fortunately, we have good treatments for brain metastases. We have gamma knife radiosurgery here, which is a very effective treatment for each individual tumor that is treated with a very high focused dose of radiation. We also can fall back on whole brain radiation for patients who have more diffuse disease and melanoma. And we also offer hippocampal sparing whole brain radiation with memantine. And this is a particular form of whole brain radiation where we actually carve out the hippocampal gyrus, which is a structure that is sensitive to radiation and which, if we spare it, can help with the cognitive side effects, particularly short-term memory issues. And memantine is a drug that has its approval primarily for Alzheimer's, but we also have a prospective trial which shows a benefit for patients with brain metastases receiving whole brain radiation. And that's another way that we can make the whole brain radiation more tolerable. And then now, since melanoma has been shown to be so responsive to immunotherapy, there's interest, I think, in looking at maybe some hybrid approaches where even if patients have diffuse brain metastases, instead of giving whole brain radiation, perhaps give them immunotherapy and maybe combine that with gamma knife. And that way we can spare them completely from the potential toxicity of whole brain radiation.
So just for the folks who are listening, at Hoag, what kind of capability do we have at Hoag?
So we have a number of ways that we can address brain metastases. Gamma knife radiosurgery is a great device and method for treating brain metastases. It's a machine that has 192 radiation sources that can all be focused in on a focal point. And in this way, we can give a very high dose of radiation that is very limited in its volume. When I describe this to patients, I commonly make an analogy of playing with a magnifying glass in sunlight.
Sure.
And we probably all have experience with this, where you can make it hot enough to burn paper at that focal point, but just a short distance away, it's like harmless sunlight. So the gamma knife works in the same principle, focusing the radiation to give a very high dose of radiation to each individual tumor. Unfortunately, brain metastases grow typically in balls that displace the brain. So we can treat with a very narrow margin because they don't tend to infiltrate very deeply into the brain. And the volume that we treat is basically all tumor. And that makes the gamma knife a very tolerable treatment. In addition to that, we also have, for larger brain metastases, our newest radiation machine in the department here, the ViewRay. This is a combination of an MR scanner and a radiation machine or linear accelerator.
Wow.
And this is a machine that has the capability of doing an MRI with the patient in the treatment position right before treatment, and the capability to adapt the radiation plan to the conditions of the day. So if anything has changed, we adapt the radiation plan to what we see. We're also able to run a continuous MRI scan during treatment. And in that way, we can actually see what we're treating as we treat it. This primarily has application in mobile tumors, like things in the lung or the abdomen, where we need to track and we need to manage the motion. But I'm always surprised when I'm trying to apply it within the brain. It can have its uses for very surprising reasons. I could go into some anecdotes if we have time. But this is a treatment that's better for larger brain metastases, which are better treated with lower doses over maybe 3 to 5 treatments, as opposed to one single dose of radiation, which for larger tumors can cause a swelling reaction.
Well, Peter, thank you so much for all this great information. I mean, I think I'd love to invite you back, and there's a lot of questions I want to ask. And so we're kind of running out of time a little bit. We cover a lot of ground. We talk about treatment with lentigo maligna. We talk about in the primary tumor setting, especially for desmoplastic melanoma, adjuvant setting for the lymph node, as well as brain mets. Thanks again. And I really, really thank you for your time. And this is a really great overview about how does radiation work and how patient can benefit from this modality. Thanks again.
Thanks. Great talking with you.